Good morning, everyone. It's an honor to be here as a fellow. I will start with a case. This is a 21-year-old female. She has a past medical history of asthma, and she presented to a GI clinic with complaints of chronic diarrhea and fatigue. So when you ask a little bit more about her history, she says she reported actually long-standing constipation and chronic abdominal pain for as long as she could remember. She said her baseline bowel movements were typically Bristol stool 1 to 2 actually, associated with straining, and her baseline abdominal pain was typically dull, and it was generalized and not associated with eating or bowel movements. About a year ago, she went on a cruise and she got an acute episode of acute gastroenteritis. And shortly after, she developed many different symptoms like occasional near syncope, palpitation, dizziness, brain fog, fatigue, and nausea. She says that her brain fog and fatigue were so severe that it made it very difficult for her to focus on her classes. So about 6 months ago, she noted a change in her abdominal symptoms. She said her bowel movements were now Bristol stool 6 to 7. They were non-bloody, up to 2 to 3 times a day. They also are associated with palpitation, flushing, urticaria, and sweats. She says she also developed episodes of generalized abdominal cramping 2 to 3 times a week, which is now different from her baseline. And she noticed that they're sometimes associated with bowel movements. She says her symptoms were worse with stress or consumption of alcohol. She tried over-the-counter loperamide, which provided temporary relief. And she tried a low FODMAP diet, which really improved her diarrhea a little bit, but not her other symptoms. She has a past medical history of asthma and migraine headaches. She has no past surgical history. Her mom has a diagnosis of IBS with constipation. She takes inhalers as needed for her asthma, and she takes Tylenol as needed for her migraine headaches and loperamide as needed for her diarrhea. She is a college student in her senior year, and she is pre-med. So this year she's very busy applying for medical schools, and she says her stress level this year is more than usual. Oh, and she has occasional alcohol use, as well as no smoking and no marijuana use. So she kind of has a pan-positive review system, so I'll go over it briefly. She has fatigue, rhinitis, conjunctivitis, dyspnea, palpitation, occasional chest pain, nausea, diarrhea, abdominal pain. She says she's double jointed. She has chronic pain in her bilateral lower extremity. She said when she was in high school, she dislocated her right shoulder 3 times playing lacrosse. She has episodic flushing, urticaria, fragile skin, easy bruising, lightheadedness, pre-syncope, weakness, headache, brain fog, tremors, and paresthesias. That's a mouthful. On physical exam, she was afebrile. Her heart rate was 70 while supine and 105 was standing. Her blood pressure was 99/64 supine and 91/58 standing. She was sitting in 99% of room air. She was a thin woman in no apparent distress. Her HENT exam was normal. She had no respiratory distress. Her lungs were clear to auscultation. She was tachycardic but had no murmurs. Her abdomen was mildly distended. She had normal bowel sounds. She had diffuse abdominal tenderness. Her skin was distensible to 1 centimeter. She had some flushing around her neck and chest area, and the scratch test induced welt. She had diffuse tenderness to palpations of her extremities, and her joint mobility was 6 out of 9 on the Beighton scale. She was a learner-oriented ×3. She had no focal neurological deficits. Her primary doctor, before sending her, had gotten some basic lab work, which for the interest time, I'll just briefly say they were mostly normal. She was not anemic. Her albumin was 4.0. They did celiac testing, GRD testing, inflammatory testing. They were all normal. Because of her urticaria, her primary doctor had gotten a serum tryptase, which is mildly elevated at 15.9. And at this point, I'm sure many of y'all may have some ideas about what's going on with this patient, so hold on to those thoughts. And for the next couple minutes, I would like to talk about the workup for chronic diarrhea. So chronic diarrhea is defined as recurrent loose watery stools for more than 4 weeks. And you want to begin with a thorough medical diet, medication, and psychosocial history, as well as a physical exam, including DRE, to look for any evidence of incontinence. And if you identified any alarm features, then you would proceed with patient-specific investigation as indicated. And if you've identified any abnormalities, then you would treat those diseases accordingly. However, if there are no alarm signs, then you would proceed with limited screening tests. The guidelines recommend CBC, CMP, fecal calprotectin, CRP, tissue transglutaminase IgA antibody, Giardia testing, and bile acid diarrhea testing. One thing to note is that bile acid diarrhea testing is not readily available in North America, and AGA recommends that if you have a patient who you're suspecting to have bile acid diarrhea, it's very reasonable to empirically treat them with bile acid binders. And if you identified any abnormalities on these limited screening tests, then you should treat these diseases accordingly. However, if you do not identify any abnormalities, then you will look at the patient and look for the presence of abdominal pain associated with defecation. If there is abdominal pain, then you may have a patient with a diagnosis of IBS-D if they meet the Rome 4 criteria. And for the interest of time, I'm not going to go over the Rome 4 criteria again, but this is the Rome 4 criteria on this box. And if the patient doesn't have any abdominal pain, then you may have a provisional diagnosis of functional diarrhea. And the Rome 4 criteria for functional diarrhea is loose or watery stools without predominant abdominal pain or bothersome bloating occurring more than 25% of the time. And they do not meet the criteria for IBS-D, and they also have to occur for at least 3 months with symptom onset at least 6 months before diagnosis. And once you make this provisional diagnosis, you want to provide reassurance, education, lifestyle and dietary advice, and empiric therapy, and look for symptom improvement. If there's symptom improvement, you have made a diagnosis of functional diarrhea. However, if you do not have any symptom improvement, then you should consider further patient-specific tests, such as colonoscopy with biopsy to rule out microscopic colitis. And if you identified any abnormalities, then you would treat those diseases accordingly. And if you do not identify any abnormality for their testing, then you have confirmed the diagnosis of functional diarrhea. So based on this algorithm, the patient I presented will have a diagnosis of IBS-D. However, there are certain clues in her history that may suggest she could have other conditions that either overlap or mimic symptoms of IBS. So without further ado, I'm going to hand over the stage to Dr. Harris, who will now talk about overlapping disorders of the gut-brain interaction.